challenge. The regional nerve blocks available to anesthetize mandibular teeth includes inferior alveolar nerve block, Akinosi-Vazirani, Go-Gates, and mental incisive nerve block. Inferior alveolar nerve block is the most commonly used technique for root canal treatment. The anesthetic solution is deposited in pterygomandibular space. The lingual, buccal, and mylohyoid nerves are not affected. The failure ranges from 43 to 83%. This is mainly because of inflammatory mediators activated by peripheral nociceptors and increased activity of TTX resistance receptors. Another reason is anatomic variations and presence of supplementary innervations. The next technique is Go-Gates, which anesthetizes all branches of the mandibular nerve, including acrotemporal, lingual, buccal, and mylohyoid. The target area for depositing of the local anesthetic agent is the lateral aspect of the anterior portion of the condylar neck. The failure rates ranges from 20% to 65%. The other technique is Vazirani-Akinosi or closed mouth technique. The target site for needle injection is the mucogingival junction of the maxillary second molar. This is the technique of choice in patients with limited mouth opening. Clinical trials showed that this technique and inferior alveolar nerve block has a similar effect in providing pulpal anesthesia in mandibular molars. The last technique discussed is mental incisive nerve block. This technique and inferior alveolar nerve block has similar anesthetic success rate. As a clinician, deciding which technique is best might be ambiguous, especially when we're going to perform a root canal treatment for patient diagnosed with irreversible pulpitis. So, the purpose of this article is to reach to a conclusion on this issue. This article has two purposes. One is to compare the anesthetic efficacy of these techniques compared to inferior alveolar nerve block, and the second purpose is to combine the evidence.
Sorry, Farnak. Hello, everybody. May I ask to turn off, let me unmute everybody. And mute all. Okay. Okay, Farnak, you can carry.
Okay. We talked about the purpose of this review. You can see the question of this review in a PICOS format. As population is mandibular teeth requiring root canal treatment with diagnosis of irreversible pulpitis. The intervention is Go-Gates, Vazirani-Akinosi, and mental incisive nerve blocks, which are compared with inferior alveolar nerve block. The measured outcome is anesthetic efficacy, and the studies study type included are randomized clinical trials.
Okay, Farnak, I want to stop you right now before you go further. Go to the previous slide, please. I want to say again, hello to everybody because of some technical problem. Sorry that some of you keep waiting in the waiting room. And I want actually to say welcome to Professor Sanjay Migulani, the past president of APEC and also the General Secretary of Indian Endodontics Society. Thanks, Sanjay, for joining us. We carry on and then we ask you to speak for us as well. Okay, Farnak, you carry on. If you recap so far, Farnak, what have you said so far, that would be good for the people that are joining us right now.
We talked about different regional nerve blocks, and we compared the success rates which are shown in the RCTs. The purpose of this
PICOS, I think you are going to show that as well. Go back to the previous slide to the PICOS.
Yes, the purpose of this review was to compare this anesthetic efficacy of these techniques to inferior alveolar nerve block, and the PCOs of this review you can see in this table. Okay, should we carry on?
Yes, please.
The inclusion criteria is the adult patients undergoing non-surgical root canal treatment in mandibular teeth with irreversible pulpitis. Studies comparing inferior alveolar nerve block with at least one another technique, and studies that reported the number or percentage of patients who achieved success. Studies that assessed the anesthetic technique supplemented by infiltration anesthesia are excluded, and studies that assess the effectiveness of medication, placebo, and anesthetic techniques are excluded too. The primary outcome measure was effectiveness of the anesthetic techniques, and the secondary outcome measure was any adverse effect reported because of these techniques. For the quality assessment, two reviewers independently assessed the risk of bias. The tool used here was a revised Cochrane risk of bias tool. Any disagreement in the assessment of risk of bias was resolved by a third reviewer. I wanted to ask Professor Babu if he could explain to us why he didn't use Cohen's-Kappa statistics for measuring inter-rater reliability here.
So your question is related to quality assessment, right?
It measures the inter-rater reliability.
Yeah, that's what inter-rater reliability is for quality assessment you are asking, right?
Yes, it measures, yeah. It is one part of the quality assessment for the selection of the studies.
See,
Professor Venkatesh, before you go further, I want to tell all of the people that today in our journal club, we have the first author of this very, very interesting article, which is Professor Venkateshbabu. So now our presenter asked him to explain about some issues in the article that she thinks it is necessary to be described. Again, I want to say thank you to you. Thanks for joining us. Thanks for accepting our invitation. Please go ahead.
Yeah. See, the answer for your question is inter-rater reliability is not a hard and fast rule to be conducted for selection of studies. If you see that certain guidelines which is mandatory to conduct systematic review. So you have two guidelines. One is for AMSTER, so that focuses on your methodological quality. Another one is PRISMA guidelines, that is for how you guys have to report your systematic review. So in these two guidelines, inter-rater reliability is not mandatory. The another thing is to be a little bit more when you need inter-rater reliability is if you're planning to give binary scores, 1 or 0, then there will be an issue between two authors. In this case scenario, we have following the well-defined criteria, plus we have two independent reviewers, followed by it has been cross-checked or reviewed by the third reviewer. So that's why we never went for inter-rater reliability. Coming to the selection of studies also, this is a small study. So hardly hundreds or thousands of papers only we had an initial screen. So it's not mandatory to have inter-rater reliability. If you see the next issue of JOE, one of our papers will get published on the influence of glide path and negotiation. In that, we have included 96 papers. So for that study, we did inter-rater reliability. Probably by next May or June issue, it will get released. If you see that paper, we have did that inter-rater reliability. It's not necessary for this small type of studies. That is the reason we never did that.
So you mean because the number of studies that you have selected are very small,
Yeah.
And it's not mandatory.
Yeah, it's not a mandatory thing. Even though if it's a big number of studies, no guideline says it's a mandatory. But to be in safer side and to follow a robust methodology, for that particular paper, we got around 96 included papers. So that's why we did that internet reliability.
Great.
Thank you, Professor. Okay, I should go on. This tool, the Cochrane risk of bias tool, comprises of 5 domains. Finally, the overall bias is judged as a low some concerns and a high risk of bias. This is the Prisma flow diagram. You can see the process of study selection. Preliminary study selection identified 1,065 articles. Finally, 5 studies were selected.
Sorry, can you go back to the previous slide, Farnak, please?
Yes.
Venki, may I ask you to tell us, because I know you did a lot of systematic review. In most of the systematic review, we see very big number on the top and very, very small numbers in the bottom. Can you explain, because we know there are a lot of postgraduate students around, and I want to use this opportunity from you, as I know you are one of the very experts in the world about the systematic review. Tell us a little about the way that you select them and the way that it should be like that. Why it is like that. Oh, microphone, please. Turn on your microphone, please.
Oh, sorry, I forgot to do that. The thing is, if you see this particular slide, the first number goes for 1065. Okay, how we get this number is total number of papers which you are getting from all the databases. I think, if I'm not wrong, in this particular study, we have used 4 databases, I think. So these 4 databases, totally combined, we got the 1065. Then the next setting is, after screening this title and abstract, we have included only 789. After seeing that title and screening, the next level of assessment will go for full text. So that's why once you go to full text, it will be a little bit lesser. You see that any systematic review, number of papers which you are getting for full text and final studies will be almost same, plus or minus 5 or 10 maximum it will be there. Because if you have any doubts, then only you will go for full text. If you see here, 6 paper we have reached for full text. After reading 6 text, one study we thought it will come under exclusion criteria. So that's why we have excluded that. Followed by qualitative synthesis is 5. Again, the next number will be for meta-analysis. That is the thing. So just don't go by the first number which you have, because the first number is mainly for combination of your databases. For example, one paper will reflect in PubMed, Scopus, Scopus. So that 165 means 4 databases, you will have the same 4 had been copied. That is why the number is more in that first database. After screening, slowly it will get reduced.
So it depends on the quality of the some of the publication as well. When it goes to the full text, you exclude some of them because of the quality of them.
Not quality of them, exactly speaking. It depends on your inclusion and exclusion criteria. So for certain things in your abstract, you won't have full details. So for those papers, you have to go into the full text to see whether the paper is included or excluded. For small example, one study which I hope you also remember, which we published umbrella review on articaine versus lidocaine, right? For example, for that particular study, for articaine and lidocaine, if you see the title and abstract, they will have only the what are all the inclusion criteria and results. But coming to my systematic review, my inclusion criteria is they have to assess the outcome only during access cavity preparation. If few of them did the outcome assessment by pipe vitality, that will come under exclusion criteria in my review. You got the point now, right? So that's why we need to read full text if you have any doubts.
Okay. Yeah, that's interesting. That's interesting. That means sometimes if even the quality of the article is acceptable, you may say that, okay, this is not going to answer the main question of my article. That is the reason that I exclude them. But I know, on the other hand, I know sometimes we may also exclude some articles because of their quality. Can you tell us as well about this?
See, here, based on the quality, you can't reject any papers here. Because even though the quality evidence is lesser, you have to take it up in your discussion section and you have to mention, just because my quality of my included paper is less, the outcome of my review is low evidence. So that is how we have to conclude. So you can't exclude any studies. If it fits your inclusion and exclusion criteria, you have to include in your review. That's why we have
them.
Yeah, you have to analyze them. That's why we are doing risk of bias. The risk of bias, your quality assessment tool will say you how is that included paper is, whether it's high quality or low quality. So according to that, you have to lead your discussion. For example, all the 5 studies can be a low quality. All the 5 studies can be a high quality. That's not our mistake. That's the topic flaw in that. So you have to say this is happened. So in future, everybody has to do the high quality research. Is our final conclusion.
Okay, thank you very much. Farnak, carry on.
Dr. Nekoofar, I had something to add here. The tremendous big number of the first search might be because of the search engine of the databases are not very accurate, especially when you work with the database of Scopus. It adds all the articles that might be not relevant to your search event.
Venki, what is your idea about this comment?
Yeah, of course. What she said is right. So that's why the number is more for that. So to be in safer side, that's why any systematic guidelines says we need 2 databases. To avoid any bias or error, we are using 3 or 4 databases. So it means it will pick a lot of unnecessary papers. Even in this thing, most of the papers is not related to dentistry also entered in that 1065. Some will be medical and all those things will be there. So all those things will be excluded at the title screening level.
Okay, thank you. May I
ask a question as well?
Yep, there is a question. Please, Marriage, please.
What would happen, just to make it clear, just to clarify, what would happen if you would have readjusted your exclusion criteria just to exclude that specific article and to make your make your power of your study higher? Am I clear?
Yeah, your question is clear. The thing is, actually, strictly speaking, you should not alter your inclusion and exclusion criteria. So that's why in systematic review, we have a protocol saying protocol has to be registered. So once the protocol has been registered, either for systematic review or randomized trial, whatever, you should not having any alteration in that. In case if you want to alter that, you can do that. But you have to discuss in your discussion section, saying that this is how we have changed our protocol because of so and so reasons. So then if you're trying to include that one particular paper, it indirectly means you are doing a bias in your study. Just because of your convenience, for whatever might be the reason, you're planning to include that one study there. So that is what it reflects.
Mm-hmm. Is there a specific place that you register your systematic review in advance?
Yeah, you have many platforms for that. The systematic review, for example, Prospero is one of the bigger websites for that. It's opening up tab. Plus you have OSF, one platform are there. This too is the most popular now. Especially Prospero is a very big platform used for registration for systematic review.
Thank you very much.
But one thing in Prospero is only clinical studies can be registered, in vitro studies can't be registered. So that you have to keep in your mind. So in case if you want to do in vitro studies, then OSF is the one more platform which you guys can think it up.
Thank you. You mean if we find some animal study that they do the same thing that we did in human, we cannot put them together?
You can put it up. You can put it up. Then you can put. So saying that you have your review will be split it up into 2 human studies, animal studies. Then you can do that. Yeah. Then it will fit into Prospero criteria.
But not for meta-analysis. For meta-analysis, the nature of the study should be similar.
Yeah, similar. Exactly. There should not be any heterogeneity in your methodology.
Yeah. Okay, thank you. We have a lot to discuss, so make it quicker. Farana, quicker.
Yes. In this table, the brief characteristics of the included studies are described. The data extracted are the author and the year of the publication, age and the sex of the patient, the tooth type is being treated, the agent and the volume of the local anesthetic used, and the intervention group. As you can see, there are 3 articles evaluated and compared the effectiveness of go gates and compared it with inferior alveolar nerve block. The article of Agarwal, Dr. Qodusi, and Dr. Saachi. 2 other studies compared mental incisive nerve block with inferior alveolar nerve block, which were the studies of Agarwal and dear Dr. Gabrai. The adverse effect of the injection is reported in only 1 study. As you can see, is the study of Dr. Gabrai. The success rate for the 3 techniques is of concern because only half of the inferior alveolar nerve blocks were successful, and this rate for go gates is 46%, whereas for mental incisive nerve block injection, it is a little higher. This table is risk assessment by Cochrane risk of bias tool. The overall risk of bias of 2 studies have some concerns in the domain of randomization process. This was because of the allocation concealment. Randomization allows an equal chance for participants to be part of any group, while allocation concealment prevents any knowledge of the selection process. In another word, allocation secures the randomization process.
Wenki, because last week also we have a discussion about the definition of these 2, because sometimes we confuse between the definition of randomization and allocation concealment. Can you give us some explanation for that, please, as well? But please turn on your microphone.
Okay, I will explain to you. So now I will be explaining you what is the difference between randomization and allocation concealment. Okay, rather to go into too much deep into definition, I will give you a small example so that it will explain you the difference between them. For example, I am doing a randomized clinical trial. So totally I have 10 patients. Okay, I have 2 groups. How do I send the 10 patients to 2 separate groups? That process is called randomization. For example, I am putting a toss. So if head comes, the first patient will go to A group. Tail comes, the patient goes to B group. So what does it mean? So I am not splitting the patient into A group or B group. There is a process which allows the patient to 2 separate groups, because the one more example is my thing is I am giving inferior alveolar nerve block. I want to know whether there is a difference in pain or not. For example, if I have 10 patients, 2 groups I have, for example, inferior alveolar nerve block and another one is mental nerve. I want to know which injection is more painful. In the 10 patients, I have 5 adults and 5 children. If I send that 5 adults to one particular group, what will be the result? They will say no pain. If I send that 5 kids to same another group, what will happen? They will say they have severe pain. So that is the advantage of randomization, saying that I am not dividing the students or groups into which group is going to allocate. It based on one particular process. Whatever the result comes, they will go into that thing. Is this clear?
Yes.
This is randomization. The next is allocation concealment. For example, I want to know what is the effect of pre-medication on inferior alveolar nerve block. Okay, pre-medication for effect of inferior alveolar nerve block. One group is placebo, another one group is ketorolac, for example, I'm telling. So patient should not be aware which tablet patient is taking. So we are masking that. For example, we are creating a capsule for placebo also, so that the patient does not know which tablet patient is taking. That is what allocation concealment. Same way, the operator also won't be knowing, because I have sealed one white, for example, I'm putting in white capsule, I'm putting the placebo sucrose into one tablet, and another one I'm putting ketorolac. So operator also won't know which group it's coming. So that is what the allocation concealment. And allocation concealment means masking the group.
Can we call it blindness as well? Is it similar to blindness?
A little bit similar to blindness, but blindness is an overall word. For example, for outcome assessor also, blinding word will fit.
So
for example,
allocation concealment is the blindness for the patient selection.
Yeah, patient selection and how the groups will be allocated. That is why it's allocation.
Okay.
So
Thank you
the
very
patient
much.
does not know which group and which tablet is going to them. That is why.
Okay. Is there any other question from everybody, from all our participants? Is there any question you can ask? Please turn on your microphone and ask Venki about your question. If not, we go further. Okay, Farnak? So far, it seems there is no question. So thank you very much, Venki. Thanks a lot.
Yeah.
One study had high risk of bias because of the bias in the measurement of the outcome domain. In this article, the operator who performed the access cavity preparation was not blinded to the anesthetic technique used. And we know that knowledge of the intervention by the person who is assessing the outcome can affect the validity of the outcome. This is the first plot.
In this situation, Venki, when we have such a bias in the blindness, are you going to reduce the power of this article in the meta-analysis, or what is the decision in that situation?
No, in this situation, we are just reporting there is a bias in that particular study. So that's why, as you discussed before, the quality will be compromised there. So that will help you in framing your conclusion. For example, if all your studies is high quality, obviously what will be our results? It's high quality. If you are including all biased or low quality studies, obviously our result will be low evidence. That is what your conclusion is.
Okay. Thank you.
Yeah. This first plot is for comparison of inferior alveolar nerve block and GO-gaze nerve block. As you can see, because the diamond, this diamond, didn't cross the, has crossed the null effect line, it shows that GO-gaze and inferior alveolar nerve block have no difference in the term of success rate. As you know, the diamond represents the point estimate and confidence interval of all the studies combined together. The second plot is for comparison of inferior alveolar nerve block and mental incisive nerve block. Although the diamond is tending to favor mental incisive nerve block, but because it touches the line of null effect, then the injection technique has no statistically significant difference. The quantitative analysis was performed for the comparison of Vazirani, Akinosi, and inferior alveolar nerve block because only one study evaluated this item. This plot is a subgroup analysis considering the type and the volume of the anesthetic agent used. As you can see, 3.6 milliliter lidocaine are used in both of these articles. As you can see, there is no significant difference between GO gates and inferior alveolar nerve block when this volume of lidocaine is used, which is similar to the primary analysis. This subgroup analysis is not performed in the other subgroups because of the limited number of studies. Secondary outcome showed that 3 patients who received mental incisive nerve block had a slight subjective swelling, and 1 patient had tenderness to palpation. In the inferior alveolar nerve block group, only 1 patient had prolonged numbness. Okay, this is an analysis we do not see in many meta-analyses. I want to say a brief explanation about it. Most meta-analyses include too few randomized participants to obtain sufficient statistical power to either accept or reject the intervention effect. When the number of participants in a meta-analysis are insufficient, the use of traditional 95% confidence interval or the 5% statistical significance threshold will lead to too many positive, false positive conclusions, which is type 1 error. In this study, it would mean that the more effectiveness of alternative injection techniques over inferior alveolar nerve block. This analysis, TSA analysis, determines the required sample size to be present in a meta-analysis for the result to be valid and reliable. It also evaluates the conclusiveness of the meta-analysis by estimating the optimal information size, and finally gives information on the need for any future clinical trials to support the evidence. This analysis is done among 3 RCTs between GO gates nerve block and inferior alveolar nerve block. TSA is performed based on the information size adjusted for heterogeneity and using a random effect model at 5% type 1 error and 20% type 2 error. I assume that these values are adjusted manually for this, this particular article. An anticipated intervention effect of 10% and control event rate of 42% is considered for this analysis. Okay, this is the plot. This is the figure for this analysis. I wanna explain. Okay. This is the Z-curve. The Z-curve is the cumulative of Z scores of the studies, which is the position of the raw result of the studies in the term of their distance from the mean value. This is the line of mean value, and this is the distance from mean value when measured in a standard deviation units.
Oh, it becomes a bit difficult now. I think we need Wenki to help, because this is also a bit different from other meta-analysis. So Wenki, what are you going to explain for us in this one?
I can understand that. This is too complicated, but if you understand, it is very, very, very simple.
Okay.
I will explain to you in simple terms.
The reason I invite you here is that because you always write very difficult articles for us. Make the life of our students very difficult, because they are going to give us exam for this type of things in the board exam. So we have a very difficult board exam at the end that they need to answer all of these questions.
To read what is the difference between meta-analysis and trial sequential analysis, if you see, you will have very less paper in dentistry, hardly 1 or 2 papers or 3 papers maximum in dentistry.
Wow.
So I took from medical thing, then I wrote a mail to whoever is expert in trial sequential analysis. While they are replying it to me, it's totally Greek and Latin for me. I can't even understand 1 or 2 words about that. Then I did a basic thing. Then I read with few of my medical friends helped me. Actually, a pharmacy guy, so he helped me that. Okay, coming to your question is, here we have used 2 analyses. One is meta-analysis and another one is trial sequential analysis. If you see most of the papers in endodontics, you will have systematic review followed by meta-analysis. Meta-analysis means it's a statistical tool to combine the values of all your studies. For example, you have 3 studies. One study you will be having 20 patients, another study you will have 10 patients, another one patient you will have 5 patients. So now the advantage of meta-analysis is I am combining these 35 studies, sorry, the 35 patients, and I am giving my result. Either it can be positive or negative. This is meta-analysis. So that will be what she explained one slide before, the diamond thing, correct? If the diamond comes to that side, it will favor that group. If it comes to this side, it will favor that group. So that is your meta-analysis.
Mm-hmm.
Now, what is the trial sequential analysis gives you is, it's the confirmation of your meta-analysis. So meta-analysis will spool you what are all the values which you have, that's all. Can you go back to the meta-analysis slide? Yeah, example. Okay, any meta, any forest plot. This is called the forest plot image. If you see this, overall, I have 53 for 1150. Is this okay? It means among this 115, 53 has been picked. So this is the takeaway message from this. So based on this, it will give you whether it's statistical different, yes or no. This is what happens here. Just go to the trial sequential analysis image.
Try sequential analysis, please.
Yes.
Just go to that image.
Of course.
Not working yet.
Yes.
I think
it's
yeah.
freeze.
Yeah, because you start actually writing something, I think the system.
Yeah, that's why it got stuck.
Yeah, maybe you can
yes,
unshare it and share it again. Okay, okay,
Yeah,
it's working, it's working.
Yeah, go ahead. Thank you so much. Sorry for troubling you, because with this image only, it will be easy for you guys to understand, or else it will be difficult for you. So if you see this, same 3 studies, Agarwal et al., Gudusi et al., and Sachi et al. So this, can you see this blue color line? That is the 53 samples which I am showing it to you. Okay, from that 0 to Z curve. This red dotted lines are there, right? So for that, what is the value which you just go down? Just is around 4,000 or something, right?
Is it 4,000 Fahrenheit?
Yes, 4,000.
4,000, yes, 4,000.
4,388 patients required.
Yeah, exactly. So totally we have only 53 patients, but to have the confirmation of the results of this meta-analysis, we need 488 samples. So that is the results of the trial sequential analysis.
Sorry, Venki, to stop you. Can you repeat this part? Because this is the most important part. Can you repeat that again and explain a little simpler than that?
Okay, so the trial sequential analysis means it will give you 2 things. One is confirmatory of your meta-analysis results, number 1. Number 2 is what is the required number of samples to have that confirmation. Right. You got the point. So in this image, totally I have, same, you just return to the same image. Yeah. In this image, if you see, my Z curve goes only has 53 samples. It is not crossing my dotted lines. So what is my interpretation? Is meta-analysis is not confirmed. The result is not confirmed.
So you mean
In
even in the articles by Agrawal, Godussi, and Saatchi, still we have problem to get the result, even if we put them together, because they couldn't see the number of patients that's supposed to be seen, we cannot go to the conclusion easily. Is it what you said?
Yeah, meta-analysis is okay. For example, there is no statistical difference between these two interventions. Trial sequential analysis shows the results of meta-analysis is not confirmed.
Yeah.
Because we have not crossed the required sample size. If you allow me, can I explain to you I have few presentation. Can I open and share it to you now?
Yes, so what I can do, I think I need to
Yeah,
make
yeah, I will.
the host, and then
Yeah.
you can give me back my role. I make you the host now, and then you can, Farna, can you share yours, please? Farna, can you, okay, can you unshare, and then Venki can share?
Yeah, just 2 minutes. Just give me 1 minute. I have to search where my presentation is there.
That's a good idea, because this is very important.
Yeah.
So while
Yeah,
we're waiting for Venki to share his presentation, I want actually to say hello to Professor Sanjay Miglani. And Professor Miglani, please turn on your microphone and say hello to everybody. We miss you, brother.
Hi, thank you. Good morning, everyone. Do you know Venki is from the same school where I passed out?
Wow.
Hi, sir.
Hi, Venki. How are you?
I'm fine, sir. How are you, sir?
He's smarter than you then.
It's the same as I'm smarter than you. So, so anyway, hi, hello everybody, and I think we should give it to Venki because the time will be less. Venki, please carry on.
That is amazing to have all of you, Professor. Sorry, Rohit, Professor Kochlar also say hello to him as well, and hello to everybody, Professor Nazari Muqaddam, and all of you. Thanks for joining. Okay, Venki, the stage is yours.
Yeah.
We are still waiting for Venki to share, but you can share whenever you want.
Just give me a minute's time. I'm just searching.
That's good opportunity to ask Rohit to say hello if he wants. Professor Kochlar. Okay, you can turn on your microphone and speak if you like. Rohit, we cannot hear you. Okay, now please. Yes, say something. Oh no, your microphone is not working for some reason. Okay, that's good to see you. And we have also Professor Gabrai, one of the article of hers actually is also cited in this meta-analysis. So if you want to add something, Professor Gabrai, please turn on your microphone and say something while we are waiting for Venki.
Hello, everybody. I'm so honored that my article has been selected in this systematic review. I'm so happy to meet professors in these online classes. But I didn't understand that why the exact reason for the risk of bias for my article.
Okay, maybe we can see what Venki is going to explain about that as well. No worries. I've seen actually Professor Nazari Muqaddam. Okay, Venki is started, so we are all quiet for you, Venki.
Can you see my slide now?
Yes.
Yes.
Okay, so this is one of the trial sequential analysis image. Here I have two groups, biodentin and MTA, okay, for pulpotomy purpose. This paper has got published in Journal of Evidence-Based Dentistry. Me and Prof. Gutman was the author for that. So in this paper, we are comparing MTA and biodentin, okay. Can you see this blue color line Z curve has stopped here till 474. So totally I have 3, 4, 5, 6, 7, 8. You got it? So totally I have 8 studies. In that 8 studies, the number of samples is 474. Can you see my cursor here?
Yes, yes.
Is 474. Whereas my based on this meta-analysis and trial sequential analysis, I need 1529 samples to confirm my results.
Wow.
You got it? This is the take-home message from trial sequential analysis. Now you understood, right?
Yes, that is amazing. I think this
Yeah.
is very informative. I'm very happy that we have you because this is one of the topics that we discussed a lot. And now you make it very, very simple for us. Thank you very much.
One more thing I will show you now. I will.
May I have a question?
Yeah, tell me.
If the Z curve meets those boundaries, it means that we don't need to update this.
Exactly. Exactly. It means already it has been. I will show you the next slide. See, how is this thing? It has already crossed. See, my expected number of sample is 131, whereas all the studies I have crossed my Z curve here. So it means you no need any further randomized clinical trial. So here I am comparing N side with placebo. Okay, this is my two arms. So for the results of meta-analysis, I am taking my Z curve till here. So the number of samples which I require to confirm the result is only 131 sample. But my sample size is far ahead. So I can confirmly show that NSID is better than placebo. You got the point now, right? So this is the take-home message from trial sequential analysis. If you see this slide, what is my conclusion? The number of sample is only 474, whereas I need more this number of samples to get my results to be positive or favoring the results of my meta-analysis. You got the point? This is the take-home message from trial sequential analysis.
And is it easy to do this analysis, a trial sequential analysis, or is it very complicated?
It is a little bit complicated, Prof. Nekoofar, because the thing is, for me also, I know how to interpret and everything. So doing this, you need a lot of statistical knowledge behind that. Even I don't have all those things. That's why I used to include few statisticians. With my help and my inputs, they used to feed the data and everything. Then they will be giving the image. Then with that image, I will be interpreting in what my way and according to our endodontic point of view.
Okay. Understood.
Technically speaking, it's a little bit tough only. From statistics, you need to have strong statistical background.
And the most important thing is to interpret that, to understand it very well, to describe that very well. The interpretation is more important for us as a clinician.
Exactly. So that's why while I'm explaining, it will be very easy for you to understand and everything. Yes. But sitting practically and doing this, it's not difficult, but you have to do a lot of homework for that.
Okay. And there are some questions that people write it for you. First one is how to evaluate the certainty of the results. Did you use grade?
Yeah, we use the grade.
Yeah, grade is necessary to be used for that purpose, obviously. And is the 474 the number of samples in one study?
No, grade is a different entity again. If you come to grade, grade will show you how is your level of evidence. For example, high level or low level, it will moderate level. That will be showing by grade. So we have in grade, again, it's a statistical tool. It will be a little bit easier if you have a free software for that. You have to load in all details. For example, what is the number of patients? What is the results of meta-analysis? What is the results of trial sequential analysis? What is the results of your quality-based quality assessment? Once you key in all those things, automatically it will give you whether the level of evidence is high quality or low quality. That is the advantage of using your grade.
Okay. And the next question was, is the 474 the number of samples in one study?
No. It's combining of all studies. That's what I told you. Here, for example, 8 dots are there, right? Combining the 8 studies, I have 474. That is what the meta-analysis is.
Do you use power of each study and multiply to the power, or it is just a raw data?
No. Just adding, that's all.
Just add them together. And another question is it enough to analyze just 2 studies to draw a conclusion for the meta-analysis? For example, the difference between IAMB and MINB injection in success rate.
Yeah. See, again, that's one of the research question which we have to put for the researchers. According to today's date, we have only 2 studies. Based on 2 studies, I am giving my results. That's why if you see my conclusion, I have wrote as future more high quality studies. It means more studies needed. That's why I did the trial sequential analysis. If you see, there is a sample deficient is there. So researchers has to tap that value to have their confirmative values.
Thank you very much. Very,
May I say something?
Can I ask a question? Yeah.
Venki, can you make me the host, because some people are waiting in the waiting room and
I will just exit now.
Thank you very much.
Doctor, can I ask a question?
Yes.
Yeah.
In another word, can we see that the number of studies not matter, the number of sample are matters?
Number of sample is a matter for meta-analysis.
For example, 2 studies enough if there are enough samples number.
See, for conducting meta-analysis, you need minimum 2 or 3 studies. That's all. Number of sample is not mandatory for meta-analysis. How efficient or how quality your meta-analysis is based on your number of samples. For example, 2 studies is having 20 patients. Same meta-analysis with 2 studies will have 200 patients. So which will be more authentic? 200 patients, right? That is how you have to interpret here.
So the number of the samples in each study, and when we add them together, is very important. So the number of studies itself, if the quality of them is good, is not very important, but obviously it is important as well. But the most interesting is the TSA is more important than meta-analysis, because TSA is going to give us a very important information about, is it necessary to do more study or not? If we want to put everything together and explain about that, we should say such a thing. Okay, thank you very much indeed. Thanks a lot. That was really very informative. I believe all of the people here are going to confirm my idea and agree with me that it was very informative. Thank you very much indeed.
Excuse me, may I ask a question?
Yes, please.
Yeah, sure.
I would like to make a comment on that. I think this is very important and interesting because in order to improve the number of the samples, in order to serve the humanity, to give a better result in terms of power, I think we can justify to make a research just the same of just previously done. I mean, if you go to a board to ask for money for research grant for research, if you go to ethical committee in our country, you have to justify that your research is original. I think it is not that important. You can copy the methodology of another study, let's say made in another center, in order to improve number of samples, I think. Like a multi-center study. What would you think about this?
Regarding the multi-center study you're asking, or justification for your randomized clinical trial you're asking about it?
Yes, in case of multi-center studies, you should plan together and you should start together. You have to have a similar proposal, maybe approved from ethical committees of the countries or the centers.
Of course, why not?
But what I'm asking is, what if I would just copy, of course, cite the other study, maybe include some authors from there, just copy the methodology and do the same research in my center in order to improve the number of samples. So would it be approved by the ethical committees or the grant committees? Or
in this case,
I understand the question that Marriage tried to raise is, for example, I did something in Tehran and Marriage wants to carry on that in Turkey, and for example, Sanjay is going to do that in India. If we use same methodology in 3 centers, is it ethically approved to copy each other like that, just to increase the number of samples?
Yeah, that is the one of the reason why the multi-center trials are popping up. So that's an approved thing. So you can do, one is for number of trials, number of samples. The another one issue is for, you have something called generalizability of your result. So if I do only in Turkey or Iran or Malaysia and India, my results will be more focused on what particular population. If I'm throwing it up into across 4 or 5 countries, so it will be, generalizability will be better. That's another advantage in your multi-center trials.
Okay. Arvin, you have a question. Please go ahead.
Excuse me. In fact, I've got 2 questions. Below the red dotted line, there was a number for this slide that Professor Venkateshbabu showed. It was 1,500, and in our article it was 400. My first question is that I exactly didn't understand where does the number comes from, and what's the formula to find how many exactly how many clinical trials need to be that our result should be confirmed. And my second question is that as we see
wait, Arvin, wait for Venki to answer the first one.
Yeah, correct. Even I want to say that. So your question is, you want to know from where that number is coming, correct? That 4,300 and 1,000. This is given by the statistical thing. So I am loading what is the difference in my RR in both intervention and my control group. So automatically that's a statistical value which I will be getting it from the computer. It's not I am modifying the value. So the computer and that is why we are doing the statistical analysis. The statistical analysis shows me this is the number which you require to have the confirmation of your meta-analysis.
Excuse me, is there any way to reduce this number or no?
No. That's what I'm telling. It's not in our hands to increase or decrease. You have to key in the number of samples which you got in your included studies and what is the positive and what is the negative. What is the number of failures and success in your statistical software. That software will automatically give you this graph and image and your values. It's not in my hands to increase or decrease.
Right. And my second question was that as we see, both of the numbers are very high, and it shows that maybe most of meta-analysis needs this TSA. So why we don't see this kind of analysis in most of our systematic review? It was, I think, we reviewed lots of meta-analysis, and it's the first time that we saw this kind of analysis.
I can answer this question because they don't have enough knowledge for that.
It's a very new analysis, of course.
Yeah.
Yeah, at least for dentistry, it is a bit new. Not for in medical sciences or in other medical sciences, but in dentistry, obviously, it is a bit new. And the reason that we invite Venki is to explain that for us. And I'm very happy. I'm very happy because this is an achievement for us. Thank you.
Thank you.
Can you make questions, please? Because I can carry on inviting other people and letting them to come inside. You can just go on my name and make me the host, please.
Professor Nekoofar, may I ask a question?
Yes, please. You carry on. Venki, you change my role, please, and then we carry on. Yes, Professor Nekoofar, please.
Thank you for the prefect lecture. And may I ask a question, the professor? When we, in the systematic review, we have a combination of animal and human, how we can use TSA about it?
Okay, see, the TSA is a different game. Animal and your clinical study is a different game. For any day, you have to focus only on your randomized clinical trial for systematic review and meta-analysis. In case your randomized clinical trial is not available, you have to step down to observational studies. In case if you not get your observational studies, then only you have to come to your animal studies. In case if you don't have your animal studies also, then only you have to come to your in vitro studies. Straight away, don't jump into in vitro or animal studies, because as everybody knows, the quality of evidence is higher in randomized clinical trial compared to animal study. So if you have enough randomized clinical trial for that particular study, why you want to select the low evidence-based studies? So in case in that point, your rationale will be killed there. So that's why any day you preferably you have to use your randomized clinical trial.
Thank you very much.
I have answered for your question, right?
Yes, thank you.
Humas,
Yeah.
Thank you.
is that enough? Do you want to say something? Please go ahead.
I think I don't understand. The TSA only for the clinical trial on human, or can we use it for animal study? Okay, to many systematic review, we have gathering of the animal study. And can we use TSA for show the number of the participants or number of the animals is enough or not?
So
Okay,
if I actually make the question a bit clearer, the question is TSA is useful for clinical trial or for other type of studies or other type of interventions such as...
No. It's purely for clinical trial. Again, in clinical, no. Even for clinical trial, yeah, Prof, you want to ask something to me?
Animal studies. What about animal studies?
Yeah. The thing is, any day the TSA is preferably has to be used only for clinical trials.
Okay.
Again, in clinical trial also, you have two things. One is binary data and another one is continuous data. Okay?
And also,
okay.
Excuse me. And also, according to your lecture, it is mandatory to use or reevaluate all of the systematic review for TSA. Yes, all of the systematic review should be reevaluated by TSA. Yes,
all the meta-analysis, not the systematic review.
Yeah,
not all of the meta-analysis. Okay.
Yeah, probably it has to go for that to show your result is confirmed or not. Again, the issue with trial sequential analysis, as I told you before, you have two data in randomized trial. One is continuous and another one is binary. The trial sequential analysis which we used is only for binary data. Either binary data means you will have only two things, 1 or 0, success or failure, that's all. If it's a continuous data, again, it's a little bit difficult to do your trial sequential analysis. So again, even 3-4 months back, we tried to do continuous data for trial sequential analysis also, but the software says it's not accurate and all those things. So that's why so far I never come across trial sequential analysis for continuous data.
Thank you.
Thank you. Wenki, I'm still waiting for you to make me the host of this meeting.
No, I think
you did it.
I'm not. How to do about that process?
Just
I must
go
not
on
have.
My name. There are three dots on top of my name, my images. Then press that, and then you need to say change me to the host.
I can't see the 3 dots on your.
If you bring your cursor on my face, otherwise you need to work as the manager and the host, because I'm the host. So
I can't track that here.
No, you are still my role. No?
No.
Can you see my face now or not?
Yeah, 1 second.
Okay.
You want me to make a host?
Okay, thank you. Okay, I'm the host now. Okay, Farnak,
Okay.
You can carry on. Please share and carry on.
Okay. So, I wanted to add a comment. As you can see, the conventional boundary, this boundary is adjusted for this study by, it could be adjusted by downwarding a p-value, a statistical significance can be seen within a smaller sample size. I don't know this analysis is done here or not. I wanted to ask this from Professor Venkateshbabu.
Sorry, I can't get you. Sorry, what's the question?
The conventional boundary can be adjusted by downwarding the p-value. So by a smaller sample size, the meta-analysis could be conclusive.
Yeah, see, the same thing as I told you, this blue line, right, is coming between these two conventional boundary.
Yes.
You got it? It means it's not confirmatory. If this blue line goes above that, it means it is a confirmatory thing. That's all. That's the interpretation of this.
Yes. Okay. So the result of this meta-analysis, which showed that no difference between GO gates and inferior alveolar nerve block was not confirmed because of the small sample size. And this review recommends the need to conduct high-quality RCTs with large sample size.
1 second. Now sorry for just go one slide before. Now you got this clear lines, right? See, our review recommends the need to conduct high quality, means you have to have randomization, allocation process, blinding, and all those things. That is the meaning for high quality RCTs with large sample size. Large sample size, which is information which I got it from my trial sequential analysis.
Yes.
Yeah.
Thank you. This table is showing the quality of evidence by grade approach. It is a method of assessing the certainty of evidence and the strength of meta-analysis. The quality of evidence for comparison of GO gates and inferior alveolar nerve block was graded as moderate because of insufficient sample size, which was estimated by TSA. The quality of evidence for mental incisive nerve block and inferior alveolar nerve block was graded as low because also insufficient information size, and also the risk of bias assessed in the risk of bias tool. As you remember, one study in this group was rated as high risk of bias because of a lack of blindness. Results of this systematic review, despite all limitations, showed that GO gates, Vazirani Akinosi, and mental incisive nerve blocks may be an alternative anesthetic techniques to inferior alveolar nerve block for anesthetizing of mandibular teeth with irreversible pulpitis. However, in clinical practice, there are other relevant factors that may affect the decision for deciding one technique over the other. For example, if the mouth opening is limited due to trauma, swelling, or microsomia, Vazirani Akinosi technique might be the preferred technique. It is more difficult to successfully anesthetize teeth with irreversible pulpitis. This might be due to increased stimulation of special channels in the membrane of neural cells that are more resistant to local anesthetic agents. Generally, the effect of pulpal anesthesia is assessed in two ways. One, by performing a pulse sensibility test like a thermal test or EPT, and the other is while performing access cavity preparation and instrumentation. Studies have showed that the first way might not be reliable because about half of the patient with a negative response to pulse sensibility test experienced pain during access cavity preparation. And this is mentioned in this article that studies evaluated pulpal anesthesia while performing access cavity preparation are included in the study. Achieving successful pulpal anesthesia is limited in mandibular teeth with irreversible pulpitis after just receiving the regional nerve blocks. It is shown that supplementary techniques like buccal and lingual infiltration increase the success rate and reduces the severity of pain consistently. In the conclusion, it is shown that GO gates and mental incisive nerve block are similar anesthetics, have similar anesthetic success rate compared with inferior alveolar nerve block for treatment of mandibular teeth diagnosed with irreversible pulpitis. Although this statement must be considered cautiously, as discussed previously. If used as anesthetic technique on their own, the success rate of each of the three techniques is a concern, indicating the need for supplemental anesthesia. The quality of evidence was rated as moderate for go-gate nerve block and inferior alveolar nerve block, compared with low quality for mental incisive nerve block and inferior alveolar nerve block.
Thank you, Farnak. Professor Venki, if you want to add something as the conclusion, please go ahead and let us know what you think about it. Microphone, please. Turn on your microphone.
Sorry.
Okay.
Can you go to the conclusion slide, please? Just one slide back.
Yes, please.
Yeah. Next slide. Yeah. If you see this, the first conclusion is Cowgirls and Moderator showed similar success anesthetic rate compared to inferior alveolar nerve block. This is the results of my meta-analysis and trial sequential analysis. If you see the last line, the quality of evidence was rated as moderate. This is coming from my grade analysis. So for grade, I am using my results of meta-analysis, results of my risk of bias, and my results of my TSA. So I'm putting into all those things into my grade to getting my quality. Can you see this chart? Risk of bias, inconsistency, indirectness, imprecision. So all those values I am keying in my grade analysis. So automatically I'll be getting it my value. That's what is my quality of evidence. So my take-home message from this review is the quality of evidence is moderate. Because the number of sample is less, quality of my study is a little bit less.
So again, if you want, as you said, a take-home message from that, that means when we use grade, we do something based on the quality, not just on the quantity.
No, everything will, grade will capture everything. See, for example, I'm putting my number of patients also, can you see?
Oh, yes.
Number of patients, your risk of bias, your inconsistency, indirectness, and all those things it will capture.
Okay, so you mean you put all together to look at even if the number of the samples also related to the quality of the evidence that they make.
Of course. So even though, for example,
analysis, it is a part of the systematic review and criticism.
Yeah, exactly. So that is why my that's how your discussion has to be teased out.
Mm-hmm. And
that is the point.
Can we say this part is the requirement to do the meta-analysis after that or not? So even if the grade showed that the quality of the evidence is very poor, then can we do the meta-analysis? Still, can we do the meta-analysis?
Yeah, of course. You can do meta-analysis. That's what I'm saying. You can do meta-analysis for any number of studies, less number of samples also. But your take-home message and your quality of evidence will get varied, high, low, or moderate. Mm-hmm. For example, if you have number of samples is so less, still you will get a meta-analysis, still you will get a positive or negative. But my evidence is low quality.
Yeah, but we need to be very careful about that.
Exactly. That's why we are using the word, take this message with caution. Because the evidence is low quality.
Okay.
That is the conclusion thing which we have to do that.
All right, then. Can you go back to the conclusion, Farnak, please?
Of course.
Bring the slide of the conclusion for us. Next. Yes, go. No, the previous. Okay.
Yeah.
Here, as we said that, for example, when we compared, on the first line, go-gate and mental incisive nerve block showed similar anesthetic success rate compared with inferior alveolar nerve block for the treatment of mandibular teeth diagnosed with irreversible pulpitis. This is based on the meta-analysis.
Exactly.
And can we overgeneralize this result and use that in the clinic or not?
Yeah, you can use. Why not? Any day meta-analysis you can use. But I said, told you before, your level of evidence is low. That's all. You can do that.
Yeah, you know, Wenki, the reason that sometimes I emphasize on a question is just to say another emphasis for all of our students that they are listening to us. The reason that I repeat some question is that. So
of course.
I want actually to raise the attention of our student to this very important issue, that the important part of this article is that we have a systematic review and critical appraisal of the articles. And then after that, still, even the quality is moderate, we put them together, we go to the conclusion, and we result something from that. This is the plan. Am I right, Wenki?
Yeah, exactly.
Okay.
That is all.
Thank you very much indeed. Okay, is there anything else, Wenki, that you want to add?
No, as of now, I think I have covered most of the things. If you guys have any doubts, you just let me know.
Can you unshare the presentation? First of all, thank you very much, Farnak, for your very nice presentation. And thanks for doing that. Thanks again for all of you that joining us today. That was really a great pleasure having all of you in one screen like that in this very difficult times of COVID-19. And I think I will also send you another invitation for the next sessions that we are going to have. We are going also to have a 3 days webinar on the effect of COVID-19 on the internationalization of higher education. And also, as in some countries, we are going back to start our schools, we are going to discuss about the post-quarantine challenges in dental education. So I will send you the invitation for all of these sessions, and I hope we can see each other again. So I give the stage to my colleagues. If they want actually to say something, please feel free, turn on your microphone and say something. Sanjay, please. Sanjay, yes.
Yeah. Yes, it was a pleasure listening to Dr. Nouri and Venki, and I think it's a good way, and I'm looking forward to more. And bye, have a great time, stay home, stay safe, and let's see when the dental schools open, and we are looking forward to it.
Thank you very much, Sanjay. Thank you. But you know, in Iran, we are going to open our schools maybe in 2 weeks, at least somehow. But we are a bit worried about that. So we are going to discuss the situation to find out, is it a good idea to open it or not? But still we have problems. Still we have some sort of patients that they go to hospitals. But the overwhelming curve is actually reduced. So some authorities decide to open some of the schools. Obviously, School of Dentistry would be the last one. But that is the issue that we will discuss that. Thank you very much for a nice message. Rohit, if your microphone is working, now we can hear you. No, unfortunately, your microphone is not working, Rohit. For some reason, we cannot hear you. Sorry about that. Sorry about that. Okay, everybody. Merish, do you want to say something? Naghmeh, anything? Okay.
Thank you very much. Thank
yes.
you very much to you and Dr. Vanki and all of the others contributing to this great meeting. Just a thank you.
Good. There are 2 more things that I want to say in just 2 minutes. One is I have a good news for our postgraduate residents, that as you can see here today, we had Professor Sanjay Miglani, one of our visiting professors. So I'm going actually to announce a very, very important things for my postgraduate students and for my fellow Iranian, that Professor Venkateshbabu is kindly accepted our invitation to become our visiting professor. So I can say that our first virtual visiting professor now today is announced. So now we have in our whole university, we are going to have our first virtual visiting professor. This is amazing. Thank you very much, Wenki. You are a really good scientist, a very young and very good scientist. And I'm very happy to have a friend like you. Thank you very much for joining us. And unfortunately, change the subject. I have a very sad news for my fellow Iranian and for Sanjay as well, because Sanjay knows him as well. Unfortunately, the previous dean of our department Professor Ashofte passed away today, so I've just received the news right now, and I'm very sad to announce that. So Professor Ashofte, Sanjay, you remember him because I remember that you were here when he gave you your license as our visiting professor.
Yes.
Unfortunately, I've received the news, and therefore I want to ask for 1 minute silence for him. I'm sure all of us send our love to him and to his family. He's one of the very, very good professor of us. He was like a father for many of us, a very good brother for many of us. I hope his soul actually be in a very good and quiet situation, and just please say our condolences to his family. Okay, thank you very much, all of you, and say goodbye now, and we see you hopefully very soon in our next session. Anything else, please turn on your microphone and feel free to communicate with us. Okay, everybody, goodbye.
Thank you, Prof.